Good afternoon, all. Respected guest speakers and my dear delegates. Myself, Dr. Raksha, postgraduate, Department of Community Medicine, Bangalore Medical College and Research Institute. On this day, it's my pleasure to welcome you all on behalf of Swami Vivekananda Youth Movement in association with Indian Medical Association, Karnataka Association of Community Health, and UNICEF to present a CME on routine immunization and COVID-19 repercussions. As quoted by our beloved late Shri Dr. APJ Abdul Kalam, learning gives creativity. Creativity leads to thinking. Thinking provides knowledge. Knowledge makes you great. Hence, continued medical education is an essential feature of the modern medicine as it furnishes the means to maintain the doctor's ability to provide quality patient care. We are honored to have amidst us our eminent guest speakers.
So it gives me immense pleasure that they have given me to welcome all the dignitaries who are presenting today. So we need to appreciate that Swami Vivekananda Youth Movement, they are taking a good initiation that in association with IMA, they are conducting CME. Last time also, 3 months back, they have conducted in IMA function hall. So I'd like to welcome all the members and directors and all the in charge of the Swami Vivekananda Youth Movements to this program. And also I'd like to welcome our President, Dr. Anuradha Parmeshwar Madam, for coordinating with them and organizing this CME, wonderful CME today. And also I'd like to welcome Dr. Nagaraj NT, the Surveillance Medical Officer, WHO, NPSP to this program. And I would like to welcome Dr. Mishaba Ani, Senior Medical Officer, World Health Organization, NPSP, today for this function. And also I would like to welcome Dr. Ranganath TS, Secretary KACH Karnataka, and also is a professor and at Department of Community Medicine, BMCRI, for this program. Next, I would like to welcome Savita S, Chartered Accountant, Head Operation Finance Director, SVYM. And also I would like to welcome Dr. Sita Ram MR, Consultant Orthopedic Surgeon, SVYM, and also a Managing Trustee. Welcome you, sir. And also I would like to welcome our colleague, Dr. Satyavati, Under Secretary, IMA, Bangalore branch. And also I would like to welcome our EC members, Dr. Vinay, Dr. Rajasri, Dr. Ansuya, and all the EC members who are gathered today. And also I welcome all the IMA Bangalore branch members who are logged in today. And also I welcome all the representatives from the Swami Vivekananda Youth Movements. And last but not least, all the members who are gathered today for this CME. I would like to welcome one and all. Thank you.
Before we continue, we'll start the program with the IMA prayer. May everybody be happy.
We'll all stand up.
Yeah, we'll start. We'll start the prayer. May everybody be happy.
May everybody be happy.
May everybody be free from pain.
May everybody
be free from time.
May everybody be free from sorrow.
May
everybody free from sorrow.
May we be the healing cure.
May we be the healing cure.
Beyond every greed and lure.
Beyond every greed and lure.
Flag salutation. No? We, members of Indian Medical Association, stand our national flag. It's our honor and glory shall be our light and strength, and its course shall be our course. We pledge our allegiance to it and realizing responsibilities as the accredited members of this national organization, we swear we will dedicate everything in our power to see it fly high in the Committee of Nations. Jai Hind, long live IMA.
Yes, ma'am. Thank you, Dr. Vinay. I'm honored to welcome Dr. Anuradha V. Paramesh, President, IMA Bengaluru, who is also Women Vice President, IMA Karnataka State Branch, Joint Secretary, IMA National Women Doctors Wing, South Zone, Vice President, Family Physician Association, Bangalore, into obstetric and family medicine practice since nearly 4 decades. I request Madam to deliver the presidential speech. Over to you, Madam.
Thank you, Dr. Raksha. So it gives me immense pleasure to be part of another wonderful webinar. And I welcome each and every one of you who have logged in, and special welcome to our guest speakers, as also the non-IMA members, in the sense the SVYM team and the UNICEF team, as well as the Karnataka Association of Community Medicine team. I welcome each and every one of you to this wonderful webinar, and this is the second of the series from Swami Vivekananda Youth Movement Group. To recollect, we had our last webinar in the month of January in commemoration of the birth anniversary of Sri Ramakrishna. And this time now, today is the birth anniversary. It is the 186th birth anniversary of Sri Ramakrishna Paramhamsa. Without speaking a few words about Sri Ramakrishna Paramhamsa, I feel I'll be failing. So I would like to just recollect my school days, when I remember that Vivekananda was the disciple of Sri Ramakrishna Paramhamsa. Sri Ramakrishna Paramhamsa, born as Gadadhar Chattopadhyaya in the year 1836, lived in the 19th century in Bengal, and his preachings have attracted Swami Vivekananda, who became a devoted, ardent disciple and founded the Ramakrishna Mission. So the birth of SVYM is because of the devoted disciple of Sri Paramhamsa, whose birth anniversary all of us are celebrating throughout India. And another few points about Sri Paramhamsa is his ideology has been modern, universal, and very practical, and can be applied in day-to-day life to solve the problems of life. So these ideologies were picked up by Swami Vivekananda. And now I would like to say a few words about Swami Vivekananda Youth Movement. This movement was started by a group of young doctors, one of them being Dr. Balasubramanya, whose sister and me have been classmates in school. And their initial mission was to help the needy. And so they started collecting samples from different doctors and started looking after the needy. And as they moved towards Mysore and the outskirts of Mysore, they found that they could approach and do better for the tribals. So concentrating on the tribals in and around Sargur, they have established a 100-bedded hospital, and they have spread their centers to many parts in Karnataka. And I'm really proud that this mission has been doing wonderfully well. Thanks once again to the Swami Vivekananda Youth Movement team, and nice to be associated with you all for the second time. Now coming back to our CME, this is another of our CMEs and webinars. In order to update our knowledge, we are doing it. And in IMA Bangalore branch, we have always been encouraging updation of our knowledge. And the two important topics that you have picked up are really the need of the hour. One is about the immunization, the latest what the government has to say for all of us. And another topic that is going to be covered is all about COVID. Prior to COVID, how are things, and post-COVID, how are things? So I wouldn't like to elaborate on this because our secretary, Dr. Pradeep, has welcomed individually each one of you. So again, I'm welcoming our past president, Dr. Venkatachalapati, our executive committee members, and also Dr. Vinay, another past president of IMA Bangalore branch, as well as all other senior doctors from FPA, as well as IMA, as well as from Bangalore Society of Obstetrics and Gynecology, and other doctors who have logged in. Special welcome to each one of you. Kindly bear with us for the few minutes delay. So now I request Dr. Raksha to take over the session. Thank you, Raksha.
Moving forward, our first session for today, Universal Immunization Program and Intensified Mission Indradhanush 4.0 by eminent Dr. Nagraj sir. I request Dr. Venkatachalapati sir, Senior IMA member and past IMA Bengaluru branch president, to introduce our guest speaker to the delegates.
Thank you, Dr. Raksha. Good evening to all. Good afternoon to all. I'm happy to introduce Dr. Nagaraj T. Can you hear me? Very happy to introduce our first guest speaker, Nagaraj N.T. of Bangalore Medical College, who has been working in the field of public health since 15 years. He is currently working as surveillance medical officer for World Health Organization. National Public Health Surveillance has immense experience in various parts of our country and is part of expert committee group in the state, BBMP and other districts for public health response and vaccination measures for COVID-19 disease. I welcome you, sir, for this webinar.
Thank you, sir. Thank you very much. Good afternoon.
Thank you, sir. Over to you, Dr. Nagaraj, sir.
Hope I am audible and my screen is visible.
Yes, sir.
Can you confirm?
Yes.
Okay. Is it visible? Right. Okay. Okay. Thank you, ma'am. Good afternoon, everybody. So, I welcome again, for joining this workshop. And also at outright, I would like to thank Dr. Anuradha ma'am and others IMA functionaries for providing us this opportunity to talk on this important topic of universal immunization program, along with measures taken to strengthen the universal immunization program in India, mission and the intensified mission IMA 4.0 currently. This is my presentation outline. First I'll talk about universal immunization program, followed by IMA and its objective and strategies. And finally, I will sum up with how the Indian Medical Association member can support UIP and IMA 4.0. Universal immunization program is one of the largest public health programs. As you can see, with our India annual target of beneficiaries, almost like 2.7 crore newborns and 2.9 crore pregnant women are the target for our universal immunization program. And we do conduct, Government of India conducts 1.2 crore sessions every year, immunization session, both which includes fixed sessions in hospitals as well as outreach places also. And currently, we have 10 vaccines against 10 vaccine preventable diseases nationwide across the country. And there are 2 vaccines are given subnationally, only in selected districts or in the selected states. Those includes Japanese encephalitis, wherever JE is endemic, that vaccine is provided. And PCV is also under scale up. It's also introduced in the country. It's getting so scaled up slowly. By next year, I think it also will be nationwide. And most important part of immunization is about cold chain points for storage. So in a Government of India's excellent cold chain services, we are almost more than 29,000 cold chain points for storing this vaccine and distribution further down to the session sites. And these are all well maintained with the trained staff and also technologically supported with the electronic temperature monitoring system also. In not only the programmatically we are the biggest, but also India is, you are all aware that we are one of the largest vaccine manufacturing country who are exporting to many countries globally. So when we look at how it all started, most of your senior members, you know very well, maybe in 1978, that's where immunization started as expanded program on immunization. But it picked up mostly from 1985 when it was rechristened as RCH program, Reproductive and Child Health Program. And at that time, you can see there are only 6 vaccines against 6 vaccine preventable diseases. That is only about measles is covered, diphtheria, pertussis, TB, and polio. These were the diseases which were covered at that time. And later in 2002, hepatitis B was piloted and introduced in the country. Then 2006, it's the JE, Japanese encephalitis vaccine is introduced. 2010 onwards, it is the measles second dose was introduced, and also hepatitis B is scaled up across the country. But you can see from 2010 onwards, you can 95 to in 1985 to 2010, not much activity we can see. But 2010 onwards, there are a lot of it has fastened up. Newer vaccines are more and more introduced every year. We had a pentavalent induction in 2011, followed by IPV, inactivated polio vaccine introduction into the schedule in 2015-16. We had a rotavirus vaccine introduction, and also we switched over from bivalent to trivalent to bivalent vaccine, which was a global program switch. We also followed in India. In 2017, it was the measles and rubella. So we started, in fact, Karnataka is one of the pioneer states who started the measles and rubella campaign in the country. Along with the campaign, it was introduced into routine immunization, also measles and rubella vaccine. And PCV was started in the country in 2017 only, but in Karnataka only last year we got it. It was first initially it was given in high endemic districts of northern Karnataka, northern India. Then we had a long tetanus toxoid vaccine, which was replaced with the TD vaccine, tetanus toxoid with low dose diphtheria. Now that is there since 2018. And the rotavirus also, which was earlier, started in a few states. Now it is nationwide scaled up. And the PCV is also going to be scaled up. It was planned for last year because of COVID. There is a small delay. Probably this year, 2022, it will be again nationwide. So just to summarize, so we have now 12 vaccine preventable vaccines against 12 vaccine preventable diseases. This is the current schedule, national immunization schedule, Government of India and also all the states, including Karnataka, follow in the government sector. So it starts with vaccination of the pregnant women. 2 doses of TD will be given. TD1 followed 4 weeks later TD2, and also if it is less than 3 years is the last when the child was born, so TD booster will be given. And only one request to all members, esteemed members present here is we still have some members following regularly using the old TT vaccine, tetanus toxoid. So kindly I request all IMA members who are still using tetanus toxoid to switch over to tetanus and low dose diphtheria. So which also, in addition to protecting a mother with tetanus, it also protects some baby also against diphtheria still, because we see still young children succumbing to diphtheria cases. Okay, then we have at birth, we call it as birth vaccination. We give BCG, OPV 0 dose, and also hepatitis B, which is within 24 hours of delivery, it has to be given. This is also one area where all can contribute to have every child get a hepatitis B vaccine within 24 hours of delivering the child. Next is 6, 10, 14 weeks. That is where we have multiple vaccines will be given in single setting. We have OPV along with rotavirus vaccine, PCV, pneumococcal conjugate vaccine, inactivated polio vaccine, and also pentavalent. So this is there, and 10 weeks we have only OPV, Rota, and Penta 2 doses will be given. 14 weeks again, it is the 6 weeks will be followed here, OPV 3, Rota 3, PCV 2, IPV 2, Penta 3. And later at 9 months, we have important measles and rubella vaccine first dose along with PCV booster will be given. JE right now in Karnataka, we have only in endemic districts. There are 10 endemic districts like Ballari, Raichuru, Koppal, Vijayapura, Chikbalapur, Kolar, Mandya, Dharwad, Chitradurga, Davangere. So these are the 10 endemic districts in the state. So that only there we will get JE vaccine. This will be along with vitamin A first dose. This is before. So this before first birthday, all these vaccine, each site should minimum vaccine each child should receive in our state and country. And this is called as a full immunization. Any child before first birthday, if they receive all this vaccine, that will be considered as fully immunized child. So our goal is to achieve this fully immunization. It should be above 90%. It should be, in fact, for measles and rubella elimination, which will be spoken later. So that we require even more than 95%. So that is the Government of India target. That is where we need all your support. In the second year of life, TB booster along with MR measles rubella second dose, vitamin A DPT booster 1 and J2. So this completes the 2 years of vaccination. So this when all the children who have received first year vaccine, if they also complete second year vaccine, then we call it as completely immunized child. So this is the our goal should be as a citizen of. So we should ensure that all our children born in our country should receive all these age vaccine so that they fully vaccinated in 1 year and also completely vaccinated with second year doses. Later, when they go to the school entry, that is at the first standard admission, usually 5 to 6 years, we give DPT booster second dose, followed by 10 years and 16 years TD. Again, here also earlier it was tetanus toxoid was given. Now this has been replaced with tetanus with the low dose diphtheria vaccine. So this is at 5th standard and 10th standard. So here also, I think you can also see whenever the children come to your OPD. So please kindly ask about immunization status if it is younger child. Even if it is school going children, ask about whether they have taken DPT, TD vaccine. So that if not, you can always provide that if it is available with you. Otherwise, you can always tell them to nearest, guide them to nearest our government health setup where they will get all these vaccines free of cost. So that's about immunization schedule currently which is followed. So coming back to after these vaccines are there, but our biggest problem has been the reach. So as I said, our target is minimum is 90% and it's 95% needed for MR elimination. So if you look, see here in the NFHS survey, that the National Family Health Survey, third one, 2005 and 6. So there you can see most of the states were in less than 50% coverage was there in most of the states across India. Even in South Dakota, was 60 to 70%. Whereas that marginally improved to 62% by 2015 after 10 years of hard work. And last survey we have is NFHS 5, which was done between 2019 and 2021. This is the latest survey available. And here you can see it's now India full immunization coverage starts at 76.4. It ranges from countries with as low as 58% and as high as 95%. So just to impress upon you all, we still have a long way to go to reach our goal of above 90%. And even to bring to your notice, there are some states which in fact worsened. They decreased also, like Kerala, our neighbor. It was its full immunization coverage has gone by 4.3%, Goa by 6%, Punjab 12.9%. So that's why even though Karnataka has improved over a period of time, but there is a very chance if we don't focus. And again, from last 2 years because of COVID pandemic, definitely we also would have slipped a bit. So that should not happen. That is why everybody needed to refocus to cover this. And when we look at the NFS survey data also, rural and urban, because most of our IM members are there in rural also, as well as we have most of them, catering to urban areas also. There is a huge difference of, even though there is increment compared to last NFS survey between 4 and 5, but urban it is only 11.5% increase, whereas it was 15.8% increase. Again, it shows more and more urbanization and more and difficult areas to reach vaccine in urban areas. So that is why, so even those practicing in urban areas have more responsibility to improve our immunization coverage. And why are these children are not getting vaccine? So we at WHO here in KSP, so we do monitor and we have some data, like almost across the nation we have covered around, this is the data from 4,50,000 children were monitored. And we interviewed around 76,000 people. So here you can see most of the issue is with awareness and information gap and also AFI apprehension. So we have around 13. So we have around 33 and 28%, which constitute almost like 50%. More than 50% of children are missing dose because of lack of awareness and also information. This is the one area I think IMA can help a lot to strengthen our reach. So that is the reason why Mission Indradhanush came. So why it was there, it is to reach the unreached with all available vaccine. Even though we have very good vaccine, 12 disease can be prevented. But reach was the difficult. With this intention, it was launched in the year 2014, 25th of December 2014. Mission Indradhanush was launched by Government of India. It is one of the flagship program. So we almost under 554 districts have been covered under various phases. We had almost like Mission Indradhanush 1, 2, Mission Indradhanush 6. In between, we had a Grama Swaraj Abhiyan also, then extended Grama Swaraj Abhiyan, and also IMA intensified. So you can see the impact already. So nearly more than 3.39 crore children were additionally immunized in addition to regular vaccination. Nearly we could reach another 87 lakh more pregnant women during this campaign. So, and so everything was, we are on track to reach that goal of 90% using these IMA campaigns. But then came this COVID-19, so which disrupted a lot of our lives and also our health services also. Main importantly, immunization. I think Dr. Rangnath sir is going to talk on that challenges what we experienced in COVID-19. I will not dwell upon them. Really, because there were containment zone, there were Anganwadi schools were closed, and work was, health staff were really working very hard. Over time, they were all stretched into COVID vaccination, COVID containment measures, and even migration started. People started from moving from urban to rural back and again. So because of all these issues, we could not reach 100%. And this is one of the estimates where we have unique estimate, that is WHO UNICEF estimates for national immunization coverage at global level. We did in 2019 and 2020 also. There you can see globally 2.3 crore children less than one year are left unvaccinated, which is as good as 1 year of our Indian target. I was talking about 2.9. So here 2.7. So it's almost like one India is not vaccinated globally in 1 year. And in fact, in 1990, it was Nigeria which had large unimmunized children. But in 2020, we look at India overtook that Nigeria. We have largest number of 3.5 million children are unvaccinated, either partially vaccinated. So that is the real, so we all have to sit and think over this. How can we how fast we can cover up this 3.5 million? So government of India also has taken some of the measures in spite of COVID pandemic. There were guidelines given, even we told how to conduct immunization safely using COVID appropriate behavior with the social distancing, masking, and hand sanitization. So with that, we have started even delivering him, and also it was labeled as immunization services, essential services, which nobody should be stopping. So all these measures also helped to little bit to gain what we have lost. As NFH survey has only told, it's 76%, another 14-15% we need to reach there. So that is why this IMA 4.2 has come now. So with the intention to achieve target, not only in districts, it's every village should have more than 90%. These are the districts selected, across India. Out of 736, 374 districts have been taken up for IMA in the coming rounds, which already started from last month. Nearly 50% of districts have gone for strengthening immunization coverage. Karnataka, we have almost like 11 districts, including BBMP. When we come to Karnataka, even though we did a good between 15-16 to 19-20, that is from NFH 4 to 5, we almost increased by 21.5%. That is the highest in the country. But in our state also, there are a lot of districts. There are 9 districts which are in red, which are below 80%, like Davangere, Bagalkote. And these are the districts which are going for strengthening further in IMA 4.0. So you can see here, state has taken these 10 districts which are below 80%, along with Dakshina Kannada and Azadi ka Amrut Mahotsav program. So all these 11 districts are going to have intensified mission in the program, where there will be enhanced immunization, more and more sessions will be done. There will be more focus on left out and drop out and resistant families and hard to reach areas. There are strategies, there are involvement of other government departments also. Micro planning will be done, headcount will be done. These are the other supporting departments, government department like Panchayat Raj, Education, Women and Child, all have been roped in to mobilize the children. So these are the 3 rounds. We have IMA round, IMA 4.4, First round is starting from Monday, 7th March onwards. It will be 1 week program till 13th of March. It will be there. So you can know whenever you come, when a child comes less than 2 years, please check for immunization. If they are not vaccinated, please get them vaccinated in the nearest IMA session site or in the refer to PHC, they will take care. And target population for this IMA is less than 2 years, that is 0 to 23 months, and also pregnant women. Even if someone comes with above that age, like above 2 years also, still they will not be refused. Even if there are children, school-going children who have not taken TD, they also will be provided vaccine. But basically targets are less than 2 years and pregnant women. And where are we doing immunization? I mean, IMA program. Again, as I said, where are we missing the children? These are the areas, chance of missing, not getting vaccine is more like high risk areas like migratory population, nomadic sites, and villages where there is a vacant sub-center. Sessions have been not held because of lack of manpower. Urban areas, slums, hard to reach areas. So these are all areas where previously outbreak were happening. Some of the photographs where these are the focus will be there, in addition to all our settled HRA also, like urban slums and very interior villages or sub-centers, and where there are vacant sub-centers, no one is catering to them. Those are the areas which will be concentrated. So we have planned for outreach and as well as mobile session. It's not only happening in a PHC. These services are happening at the community doorstep in the villages, Anganwadi schools. They will be doing a session, and also they have planned team coverage also. So, and most important part of this IMA is the pillar is head count survey. All these areas selected for intensified mission in the Dhanush in 11 districts. They have, health worker have gone to from house to house, searching for 0 to 23 years and pregnant, and registering their name, writing down their name, writing their vaccination status, whether they due for this month or next month. They will be tracked for next 3 months, so that they all will receive essential, missed, or whatever it is due vaccine that will be done. And after 3 months also, they will not be left. They will be included under our routine immunization registers. So just last slide from my end. What's your role as a members of Indian Medical Association? First and foremost, you're all champions in the society, and you have a very good rapport with the community where you practice. Please use your influence to create awareness and also share the information to parents about the importance of immunization. Especially, there are a lot of posters, very good posters, banners, will be provided by government free of cost. Please display them about RI schedule, when to take the vaccine, all those things, and also VPD, vaccine preventable disease also, which to report and all. And also about awareness about AAF again, because I said fear of AAF is the one major factor why parents are missing out after taking 1 or 2 doses. They will drop out. So just you need to create awareness about also small minor adverse events which happens following immunization. And advocacy for timely and complete. Yes, this is the most important, because they do start with session 1 or 2 vaccine, then they drop out. That should never happen. So kindly keep checking the vaccination status till the child completes 2 years. And you can also become partner with health department. You can provide a space in your premise for RI sessions, especially in urban areas or slum areas where it is difficult to find even place to sit and do vaccination for a large number of children. And also, Government of India has given a guidelines to provide vaccine to the private sector also free of cost. There are guidelines. You can always approach your nearest RCH officer, district RCH officer, who is happy to provide you that vaccine free of cost. And also your support is needed in case of adverse events following immunization, whatever it may be. It's whether anaphylaxis or even a small syncope. Whenever they get child to your clinic, kindly handle that immediately and ensure essential services are provided. And in addition to that, as we already talked about birth vaccination, within 24 hours, we need to give hepatitis B. Wherever delivery is happening in your institute, please ensure that it is provided immediately. This schedule is strict, and all the vaccine is given immediately. And the most important, which my colleague Dr. Mishba is going to talk in the CS and AFI, which you see during your practice, in your day-to-day practice, in your hospital, in your visits, you will see these cases. Please don't forget to report immediately to nearest your district or city officer or district health officer, or even our contact number will be shared and discussed with also. And your help in community engagement during IMA days, how you can help in intensified mission in the Dhanush. It is, we still have small pockets of community which are hesitant to take the vaccine, injectable vaccine, especially fever of fever and all. So kindly engage them, just reassure them, use your influence on them. They believe you more than anybody else. So one assurance from IMA member will help in mitigating this vaccine hesitancy. And the last but most important is we know the social media power. So Twitter, WhatsApp, Facebook, YouTube channel, we all use. You also will be using, but we always use it to know just to get information. But you should be sharing the information to others. So kindly use your Twitter handle to send out the message, share the immunization schedules, share about why it is pneumococcal conjugate is needed. Tell community about IMA 4.0 program is coming, get the vaccine, or Pulse Polio NID program. So kindly use your channel to reach out to the community rather than just keeping it as just to receive the information. You have, most of you use the Facebook live chats also, you can do it. So kindly use this to spread positive messages about our routine immunization. So this way, your support will go a long way in strengthening immunization in India, particularly in Karnataka, so that we can reach our goal of 95% more than, so that we can eliminate measles and rubella next, and also we can protect up from all other diseases. Thank you very much. I think questions and discussions we can take after all the three presentations are over. Thank you. Thank you. What to you, ma'am? Back.
Thank you, sir, for the knowledgeable session.
Now.
We request the delegates to kindly send your queries on chat box, which will be answered in discussion session at the end. Next session is on strengthening vaccine preventable disease surveillance by Dr. Misbah Hani. I request Dr. Rajashri, Madam, EC member, IMA Bengaluru branch, and active women doctors wing member, who is now working as family physician, to introduce our guest speaker.
Thank you, madam. Thank you for such a kind introduction. Let me introduce, I have got the opportunity of introducing Dr. Misbah Hani. Dr. Misbah Hani is from WHO. Yeah, Dr. Misbah is a public health specialist working in WHO for more than 10 years with experience in high-risk areas in India like Uttar Pradesh, followed by working as a state coordinator at Andhra Pradesh. Currently, Madam is in Bangalore for nearly 3 years, and her present work profile is strengthening immunization with technical support for new vaccine introductions and disease surveillance strengthening. Welcome you, Madam Dr. Misbah Hani, for your talk about strengthening vaccine preventable diseases surveillance. Welcome, Madam.
Okay, continuing with what my colleague Dr. Nagra sir was telling. So when we speak about immunization, we do all of the immunization services in children also to ensure the vaccine preventable diseases are not there in the world. At least the mortality and morbidity because of them has reduced. But how do we come to know these diseases are there or no? And that is when we require the VPD surveillance. So in my presentation, I'll be speaking about 5 particular diseases for which vaccines are already there in children. They're global and a little bit of India scenario. What are the case definitions which will help the doctors to report such cases? And what is the public health response which happens when you report a case? And how has COVID pandemic affected this overall? So we always think, why do we need surveillance? So we have been reading this before. We need surveillance to understand where the disease is occurring, to whom it is occurring, to which person it is affected, and to drive our immunization activities. And end of the day, also to understand, has the disease transmission gone? And I think in a way, COVID pandemic has shown us the importance of any disease surveillance over here. So I'll go back to one of the first earliest disease surveillance, which was started in India, that is for polio disease. And what has happened therein? So you all know polio has been almost gone from most of the countries except 2 endemic countries which are there in cases of polio, somewhere from 400,000 cases. But from past 2000 onwards, those numbers have been very minimal. So the 2 types of polio virus which has been almost eradicated from the world is type 2 in 1999 and type 3 in 2012. So what is the situation now? The situation is in the year 2021, there were 6 children who were found to be affected by polio virus. And one of them was out of the endemic countries. And the second in 2022, till now, 1 child has been detected. So what we would like to stress upon here is polio virus is still a very big public health emergency of international concern. So even a single case coming out of any of these non-endemic countries becomes very, very important for us for all the hard work which has gone. So in 17 February 2022, I think we all read the news and we were aware there was 1 polio virus case detected in an African country called Malawi. And the reason that I'm trying to stress upon here, this country did not have a single case of wild polio virus since 1992. So it's been almost 20 years they have been polio free. It goes to show that importation of virus from other countries is still very much possible and we should not be letting our guards down. So the only way we can pick up this importation till the time polio is out of the world is by a very good surveillance system. So India has achieved most of these milestones. If you all recollect, 2011 was the last case of polio virus in India. And from 2014 onwards, we have received a certificate of being polio free. And we have also introduced various vaccines. OPV was always there in the system. And also now IPV from 2000 strategies has been surveillance. So surveillance, where we call AFP surveillance. So here we went beyond a typical polio case. And having a case definitions helps in streamlining surveillance system. So you all would be aware of this definition where we speak about any onset of weakness or floppiness in any part of the body less than 15 years of age in a child. We take it as AFP case. So all such cases have to be reported if we have to pick up any transmission, importation, or even VDPV cases. Even if a case presents to you late at the hospital, which could happen because of pandemic, up to 6 months of duration also, if you come across such a case, kindly report it as AFP. So what are the cases we go ahead and report? It could be having a current flaccidity. It could be a mere history of flaccidity, or also it could be a borderline case. So I would say when in doubt, kindly report a case of AFP. So as I was telling you, going ahead beyond the typical poliomyelitis definition, other differential diagnoses which are there, common conditions which occur with AFP are put up in the slide. It could be a mere Bell's palsy, facial palsy, traumatic neuritis, even an isolated neck palsy or a Todd's palsy. So we do come across such cases in the OPDs and in patients, but kindly make sure they are also reported if they're less than 15 years so that testing for polio virus can be done. So what do we do? So a virus sample is tested, a stool sample is tested for virus by sending to a very good WHO accredited lab. We have one in Bangalore also, where it is detected for polio virus as well as any kind of VTBVs. So it is the medical officer from the government hospital also comes in contact and they ensure the sample is collected from your respective clinic or area. So when I put up this slide, I'm trying to impress here that it does not limit ourselves to AFP surveillance of India alone. So we go beyond India. So every country over here, if you can see African, American, even those developed countries which have eradicated polio from long ago, still go ahead and do AFP surveillance. So as I said, till the time we do not make sure that both the other endemic countries also stop reporting cases of polio, we will continue AFP surveillance. So what happened in COVID pandemic right now? So AFP surveillance, if you can see over here, the India map as well as the Karnataka map, we need a quality standard of AFP surveillance. We have to test a minimum number of samples. Here we say at least 2 samples for less than 100,000 population in children and see that there is no polio virus transmission happening. And that is a good quality standard to maintain. So if you can see the Karnataka map, there are some districts, particularly the Bangalore and around Bangalore, where the quality of surveillance is not up to the mark because the number of cases has drastically dipped from 2019 after the pandemic, if you can see the graph down over here, it's almost become half of the cases reported. So what's happening? The detection important that we maintain this quality of surveillance. So moving ahead with pulse polio and even polio eradication, our next priority has also shifted to measles rubella elimination by 2023. In 2017, I think Karnataka was the first state to take up measles rubella campaign in a very large way. And most of you have also supported in the campaign. As in polio eradication, the strategies remain same. A very good immunization program and a very good sensitive surveillance is required to declare India as measles and rubella eliminated. To make it simpler and to expand the basket where we can collect more and more samples and test for measles and rubella, the case definition has been made simpler. So it is any person with fever and maculopapular rash, or any person in whom we suspect measles and rubella infection. So it is very, very simple. If you come across any such case who's having fever and maculopapular rash, kindly report it for suspected measles and rubella so that we test as many samples as possible and see if the transmission of virus is still going around. So this could be the differential diagnosis for fever with rash. And you can see apart from measles and rubella, there are also many diseases. It could be dengue, scarlet fever, chikungunya, and many other diseases which can prevent in the same way. So any of these diseases coming to your notice in your clinical practice can be reported for testing for fever with rash surveillance. And what are the samples collected? Between 7 days of onset of rash, we have sample collection of throat swab and serum, or also only a serum sample if the case presents to us later. So we are also testing for virus isolation as well as IgM antibodies for measles and rubella. So it is a single case reported to us also helps in identifying if there is any impending outbreak in the area. So when you give us a single case, we also see the data around in the same area and see if there's any other outbreak happening. And that will help us in early detection of any case. So again, during COVID pandemic, if you can see the graph in the below part of the presentation from 2019 and March, when COVID pandemic had not started in 2020, there was a good amount of cases reported and testing happening. And this has also come down after April when the pandemic hit us in 2022. Of course, there has been some improvement in the last quarter, but we are yet to catch up the pre-COVID times. The third disease which I'm speaking is going to be about diphtheria. So diphtheria is one of the diseases which we all know is very deadly because of the high mortality rate which is there and which can be easily preventable by a very good vaccine which is also available. Of lately, we have been seeing cases of diphtheria, and that's the reason, one of the reasons when Dr. Nagraj sir was telling about introduction of TD vaccination was required even in a higher age group. So if you come across any case with this case definition of laryngitis, nasopharyngitis, or pharyngitis or tonsillitis, and also having an adherent membrane over this tonsillar or pharyngeal area, kindly report such cases. The timely testing of such samples can be conducted. So with the help of the support of the government, these samples will be sent to our accredited WHO lab in Bangalore for testing for culture and RT-PCR testing of diphtheria also. So this is from 2019 to 2020. See, 2019, if you can see the yellow graph, there's a very good reporting of all suspected diphtheria cases. And we all know it is very seasonal, starting from June to November. But the same number of cases reporting has dropped down in 2020 and 2021. And that is when probably we are missing out number of cases of diphtheria still happening in the field, and we may be missing out outbreaks and where we cannot prevent further children also from getting them. So I have also highlighted Karnataka in this slide to show that even in 2019, we have reported 728 cases of diphtheria from Karnataka for testing. And even during pandemic, around 200 odd cases have been regularly reported. So hopefully in 2022, onwards, we can go back to our pre-COVID times, having a good surveillance to ensure that no child suffers from this disease, which can be prevented if you do a good surveillance and a good limitation of any outbreak. And the other disease is about pertussis, for which also there's a vaccine available. So any cough, any person having a cough lasting for more than 2 weeks or in any duration in infant can be reported for testing for pertussis. But they also have to fit one of the obvious signs and symptoms given, that is paroxysm of cough, inspiratory whooping, or post-tussive vomiting, which happens. So if you come across such case where you're also rolling out other diseases which have got cough for a longer duration like TB, asthma, you can please go ahead and report this case for pertussis, where IgG sampling will be done as well as nasopharyngeal swab will be taken to check for culture as well as for antibodies. And the last disease which I'll be speaking about is a neonatal tetanus. So many of you would not have seen or probably not come across such cases of neonatal tetanus because we have very good immunization coverage in pregnant women. Every pregnant woman is she is very aware of, as it is not, even after elimination, you can still get a case of neonatal tetanus. For any clinician, if they find a suspected case, so any neonate that is 0 to 28 days of delivery, who can suck and cry normally during the first 2 days of life, but between 3rd and 28th day, they cannot suck properly and become stiff or have convulsions or spasm, you can, and if you're suspecting a neonatal tetanus as a clinician, you can report this case for further investigation in the field. So one more thing which India has achieved in 2015, WHO has congratulated India on achieving the milestone of maternal and neonatal tetanus elimination. But as I said, elimination is when we do not have cases in a huge number and there are very, very less importance, but you can still come across sporadic cases. So whenever a single case is reported from the clinician side or from a hospital or a medical college, there are many things which go on in the field. Like if you report a case of AFP, there's a lot of active case search done in the community for all the diseases to see if there's any other case in that area, in that neighborhood, in that workplace or school. Even for measles and rubella, we do active case search. Along with that, we also drive immunization activities when you report a case. Any case which gets confirmed or outbreak is flagged, we see whose immunization coverage is left and we drive those activities. For diphtheria and pertussis, also we go ahead and ensure they get post-exposure prophylaxis of chemoprophylaxis is also given for their close contacts so that we can prevent the transmission. So most of our medical colleges or hospitals are also part of the reporting network and have been reporting in this particular format every Monday from almost 15 to 20 years. And if during COVID pandemic, you people could not have done it, so I think we should go back to the system of making it streamlined. And this reporting format can be sent to the RCHO every Monday. Even if you do not have this format, which is also a documentation to know that you're doing a very good surveillance, you can report all such cases by any fastest mean by phone or WhatsApp. You do not have to wait for a Monday to come to report any such case, and kindly do not wait for any pending investigation and final diagnosis to rule out other differential diagnosis. As I said, surveillance is about finding the transmission of disease. So we check as many samples to know what's happening in the community, irrespective of the final diagnosis of the case. So this is one particular slide which will be very helpful for what all I spoke in the last 10-15 minutes. It helps in summarizing what cases have to be reported. So if I can again just revise, AFP is up to 15 years, but all other measles, rubella, diphtheria, pertussis can happen in any age group. So any clinician, need not be a pediatrician also, can come across such cases of for surveillance. So if this can be displayed in your own OPs or IPs, it will be a revision for us to know, okay, what are the cases and what sample has to be sent. So this slide is a retaliation of what my colleague just spoke. So it is very, very important whether we require your support for RI as well as for VPD surveillance. It could be in displaying posters for RI and VPD surveillance. Along with that, you come across any case of AEFI, that is adverse event following any immunization, can also be reported to the system so that we can investigate those things and see whether is it because of vaccine, is it because coincidental, and that helps in building the confidence about vaccines in the community. So this slide, as already told by my colleague, we need your support for RI immunization coverage improvement, your support in community involvement, as well as to report all cases of BPDs and AFIs. And to whom to report it to. So RCH officer of that concerned district will be nodal officer for reporting any such surveillance medical officers who are working from WHO for the concerned districts with their phone numbers. So if you are coming across, if you're working in any of these districts, you can kindly put a message to them, WhatsApp them about a case you have come across for further investigation. So I would like to end my presentation by saying we have to understand that outbreak anywhere can be a threat everywhere. So even a single case where we can limit outbreaks is very, very helpful. So thank you.
Thank you for the wonderful session, ma'am. Moving on to the next session, Pandemic Implications on Health Economy by Savita S. Madam. I request Dr. Mohan Kumar Sir, EC member, IMA Bengaluru branch, retired Joint Director, Department of Health and Family Welfare, to introduce our guest speaker.
I switched the share stop by the share.
Hello. Good evening. Hello.
Sir, you are
Hello.
audible, sir.
Hello,
Yes, sir.
sir.
Go ahead, sir. Audible.
Good evening. I thank our President, Dr. Anuradha Parmesh, for giving me this opportunity to introduce the speaker. I am Dr. M. Mohan Kumar, physician working in Victoria Hospital. Dr. Savita S. CV goes like this. She has done CA in November 2006. And she has got an experience overseeing the administrative and operation focus like finance, HR, relationship management and support service function in Swami Vivekananda Youth Movement. She is the head operation and director finance. And she is a management consultant, management of corporate finance. And also she is a consultant in Nagdeep, Satnarayan Co. and MSS and Co. Over to Dr. Savita for her lecture. Thank you.
Thank you so much, sir. In fact, this is the probably fortune that wherever CES goes and talks in doctors forum, I'll become obviously doctor. So invariably, so I'm basically a chartered accountant. So from Swami, and Director Finance and Head of Operation of Swami Vivekananda Youth Movement. I'm thankful to IMA and SVYM for giving me this opportunity. So many times I'm kind of worried how to address any doctors, because many doctors will opt for medicine because they are really, they hate numbers. So any finance person, how to address any doctor. So that is the thing. But when I joined SVYM, I learned that so doctors are chartered accountants. In fact, especially at SVYM, all doctors are kind of, they have a knowledge more than a chartered accountant. And slowly they are converting chartered accountants into a doctor. So that is the thing. What? So I'll just share my screen. I hope it is visible. Yeah. In fact, when Dr. Deepak told me that, can you talk on pandemic implication on health economy, I asked, is it in a finance forum or a doctor? So he said doctors. So then I said, okay, let me try. So here what I can say is I'll try level best to talk on this topic. So first of all, I thank each one of you for standing with us, in fact, risking your life and safeguarding community. So we have to be thankful for entire health workers, including doctors. So thank you for that. So when we see what are all the areas affected by this pandemic? So is it only the health sector? No. There are so many areas, including the education, wealth inequality, so reduced lifetime earnings, livelihood, everything got affected. There are so many areas got affected because of pandemic, and India is not an exception for that. I'm not going to talk about all this stuff. Probably I'll restrict myself only for Indian economy, especially the health sector, how it is affected. So our 50% of our GDP is from service sector. You know, the service sector is containing this. It may be health, IT, so whatever it is. So 50% of GDP comes from service sector. Because of this COVID, there was adverse effect. So on the most of the health sector, most of these sectors, including health sector, I can say being the sixth largest world consumer market, but we have bad impact from COVID. And this health sector, so the ratio between the private and the public combination is, the private health system is more than 60% in India. So that is affected very badly during this pandemic. Maybe I'll just tell you how that got affected. Before getting to what are all the areas, how it got affected, I just want to touch upon what do you mean by economy. So when we see the definition of economy, it is nothing but it is a larger set of production and consumption of goods or services. There has to be a supplier, a producer, there has to be a supplier. So then only the economy can be formed. So if there is proper management of demand and supply, there will not be any problem, and there is a proper availability without any scarcity of resources, then also the economy will be good. But when there is mismatch of demand and supply, so what I mean by demand is there has to be a demand for health facilities, health service. At the same time, there has to be a provider for health service. Similarly, there has to be a availability of all kind of resources, maybe infrastructure, inventory, including consumables, medicines, other things, skilled manpower, all those things. If there is any mismatch, then it will have impact on this economy. So this COVID has brought in this kind of an impact on our Indian economy, especially the health economy, how it and mainly the health services, and then the cost effectiveness. Health services includes all kind of services, IP, OP, whatever it is. So then cost effectiveness is something very really effective, cost per bed. So and then the for that the affordability of the community, all those things. Inventories, availability of all kind of PPEs. There was initially the first wave, there was scarcity of PPEs, and we have paid extra money to buy. The rate was double, triple, and other things. Similarly, the contribution to the gross domestic GDP, gross domestic product. So these four really matters for the health economy. We will just see how each one of the things has impacted by this pandemic. So I have prepared a table. What was the impact in the first wave? I call it as an isolation period. Maybe second wave has started to recover, and then third wave is kind of recovered. Maybe this is the language of what you people use, so that's why I thought I started to use that language. So when we see hospital visits, OPD and IP, so the private health sector, in the private health sector, it has witnessed about 80% fall in the patient visits, test volume. So revenue drop was nearly 50 to 70% in the first wave, maybe end of March 2020. I need to quote here, because of this, in the quarter one, the revenue drop was only from health sector around 14,000 crores to 24,000 crores. That was the drop in the first quarter itself. So that was huge. So, and usually the hospital setup, when it comes to private sector, in the health sector, the cash, there is a cash flow problem. Always there is in the certain research reports say they have hardly 19 to 20 days of cash flow. So not more than that, because all these secondary and tertiary providers, mainly they are they invest in assets. That is the reason they always have a cash flow problem. Most of the things will go on capital investment or a repayment of a loan, debt servicing. So that is what the hospitals will be doing. That so when these OPD or maybe the footfall started to decrease, obviously the cash flow got affected. Maybe I'll cover it in the next stage. Similarly, the occupancy level have fallen into 30-40% by March 2020. It was average was about 65 to 70%. That was so. But in the third wave, it started to pick up, but definitely not to that extent. But only thing was occupancy increase. Similarly, the second area, because of a safety and a precautionary expectation to control infection, in the first wave itself, a lot of investment gone only to the operating expenditure like PPEs. So in the first wave, there was a less investment on ICU or HTU beds, but in the second wave, because of the demand and the kind of this is what we had, there was an expectation of setting up of ICU and HTU beds along with the other PPEs. And one more important area is to manage these ICUs and HTUs, there was a requirement of skilled manpower. So that was not there in most of the private as well as public sector hospitals. So, and whenever they wanted to have that kind of a manpower, obviously investment or maybe the operating expenditure increased. So the third wave is, I can say, in the second wave, ICU and HTUs has been in most of the investment has most of the hospitals invested on these things. Third wave, the maintenance itself increased. So I'll take an example here. So many hospitals, including our hospital, we invested in oxygen generation plant and many other such kind of a thing. Now our monthly electricity bill has gone up by about 50 to 80,000 rupees per month, and annual maintenance charges by 8 to 10 lakhs. So, and the usage has 0%. Now I can say it is nearly zero or maybe the 0%. So the similar experience for other private hospitals also. So now the maintenance of the equipment is kind of has become a burden for private hospitals. Obviously that has increased the cost per bed. Maybe I'll come into that later. And the third important area is elective procedures. So it has dropped to 18, only 18% opted to go for elective procedures, like maybe the especially ortho kind of a thing. So that has decreased inpatient and the revenue or maybe utilization of bed occupancy, everything, utilization of equipment and other things. So that is the main impact. And slowly in the third wave, that was continuing even in the second wave also. People were scared to go to hospital. They were postponing whatever the thing, the procedure they have to undergo. So third wave, even after 1.5 years or nearly 2 years, slowly people started to come out and started to schedule. It is picking up, what I can say. So the fourth important area is e-health market. So because of non-availability of public transport or any other, there was lack of mobility. So, so then obviously people were depending more and more on teleconsultation, telemedicine kind of a thing. So that has, I can say, in the third wave, it got standardized, and also there is it is expected that it will reach about $10.6 billion of total turnover by 2025. So maybe doctor community has to rethink how I will what I can say equip myself into that kind of new market. That is new for many of the doctors. They are not used to it, especially youngsters will immediately get into that, but especially who are already there in the field for about 25 years, 30 years, may have to get into that kind of, used to that kind of e-health market. digital health market. So the fourth important area is the cost of capital. As I already mentioned, in the first wave, the public sector was a key player. In fact, most of the private hospitals were attending only the emergencies. So obviously, whatever they have already invested, so on that they were paying about the cost of capital was 14%. In fact, they have to pay their loan repayment or maybe their maintenance. So it was coming about 14%, but on that return was hardly 7%. It was two digit before, but it is reduced to 7%. So that is also obviously tend to kind of what I can say, the reducing the manpower or maybe reducing the salary kind of a thing. So that is in the second wave. Along with that, there was a requirement of additional investment for isolation beds. So and then the PPEs, all those things. So that also increased the burden. But in the third wave, so second wave, there was investment, but third wave, there was mismatch in the demand and supply. I can say there was the hospital invested expecting that third wave may require this kind of a facility. But in the third wave, hardly any such kind of a requirement. You all know that. So the return on that investment was, I can say, remained the same. So that it has not really increased. Also, there was one more added expenditure was the maintenance cost of those investments that also added to that. So now we'll look at how the revenue and cash flow got affected because of this. I've already told you because of this, there was loss of 14,000 crores to 24,000 crores in the health sector alone in the Q1 of 2021. It is, in fact, in the second and third wave, so they started to recover, and also the private hospitals were treating with 60% capacity with the Ayushman and other 40% with the private other insurance or maybe the cash paid patients. But there was cap on even the rates, so that also affected the cash flow. And moreover, the settlement of Ayushman that got delayed, that has affected the cash flow as well. So there was heavy fixed cost, as I mentioned already. There were already existing housekeeping staff and then the paramedics. It was there, but hardly any revenue. So it has, in the first wave itself, most of the people reduced their manpower because of reduction in the revenue. But in the second wave, there was need for a skilled manpower to manage ICUs and HDUs and other isolation wards, but with a higher cost. So again, that is one more burden. But in the third wave, balancing between this recovery of fixed cost, variable cost, capital investments, also it got affected by government regulated price of Ayushman Bharat or whatever, affected the overall revenue and hospital performance, what I can say. I would like to touch upon these two things. One is the health insurance and a government policy. So health insurance, even during COVID and also now also I think it is continuing. So whatever it is, so the health insurance coverage as well as a sum assured, both got both increased drastically. So because of the requirement or maybe hospitalization. So I can say the insurance company's performance got coverage. They got the clients, but there was lot of claim also. Similarly, the government policy. So especially though there was a plan to have a universal health coverage, health for all. So Ayushman Bharat and National Digital Health Mission, it increased its coverage, and that has been even the private partner also could take a role in that, so increase their reach and presence using this thing, especially the rural area or maybe tier 2 and 3 cities. So what are all the these are all the impacts. How the recovery started? Mainly medical infrastructure and availability of healthcare services that has improved in India because of the requirement. So both in private as well as public sector, tier 2 and tier 3 cities, that is taluka level or district level, whatever we call. So that is one. And in the union budget 2021 and 2022 also, our finance minister has announced lot of investment in health infrastructure. I can say it is increased by 137%. So overall investment in the health sector got increased by, they've got an allocation of 2,23,846 crore. So that is the allocation what health sector got in the financial year 2020. So also, so there was support from other CSR, the corporate social responsibility, whatever the companies they have to spend on their CSR activity. Most of the money they have diverted for this health sector. So that also increased the maybe used for a betterment of, I can say, the few rural hospitals or even urban setting up of ICUs, whatever the thing. So that, so I can say it is doubled. It was 2,500 crore exclusively for health sector. Now it is 5,470. The recent data says it is 5,475 crore only for the health sector, excluding water sanitation, nutrition, whatever it is. As PM case, you must be knowing, so totally some 10,990 crores collected till March 2021, but hardly they have spent 36% only for a COVID case. So the next area in the in terms of recovery is the employability. So here health employment, initially it fell drastically, but it has the health sector is the one sector which has created 27 lakhs of new jobs in India. Similarly, higher pay. So whatever this chart shows the same thing. So, and then the earning change, I've mentioned already, there was a requirement of a skilled manpower, and also and also there was scarcity because of a new systems or a new isolation wards, other things. So there was a requirement of a doctors, paramedics, and medical care equipment. So it is ended up with increased salary. So maybe the per capita income, or I can say in the health sector, health worker income got increased. Private hospitals or public hospitals, facilities improved and started to do better. But few recommendation maybe from the finance communities. So one thing is addressing the consistent manpower and a skill gap. So there is a facility. This is specific to public sector, but to manage those facilities definitely needs skilled manpower. So capacity, investing on this capacity building is something which is very important. At the same time, private sector. So obviously the facilities increased in the public sector. To compete with them, we need public sector has to improve and increase the patient's footfall so that cost per bed can be reduced. And private sector, the request even for the IMA, the private sector network, proactively create awareness and also bring mechanism to cover people under insurance scheme, so that especially the middle class people, it can improve the health seeking behaviors, also patient's footfall. So that will obviously end up with the reduced cost per bed and reduced poverty. So the poverty, because of a health itself, one family can really go into a BPL or maybe the below poverty line. So there is already I've mentioned there is high rise in the health coverage, but still it needs to improve upon both in terms of number as well as the coverage. So these are all the things what I wanted to talk on. Thank you so much for your support and maybe the care. Thank you.
Thank you for the wonderful session, ma'am. Next, the most important session of the day on post-COVID and long COVID by Dr. Sitaram sir. I request Dr. Rajeshri madam, EC member, IMA Bengaluru branch, to introduce dear sir.
Thank you, madam. Yeah, I am Dr. Rajeshri. Let me introduce Dr. Sitaram MR, who is a consultant orthopedic surgeon. He is the president of Swami Vivekananda Youth Movement, and he heads the health sector of Swami Vivekananda Youth Movement too. He is a managing trustee of Disha Foundation in Mysuru. He is a member of Regional Steering Committee South Asia region, and he is a convener of National Steering Committee of FANSA, that is Freshwater Action Network of Southeast Asia. He has more than 30 years of experience in mentoring various community level initiatives. He handles training of various institutions like State Institute of Rural Development and international and national fora on WASH, that is water sanitization and hygiene. Over to you, sir, for your topic on post-COVID and long COVID syndrome.
Thank you. Thank you, Dr. Rajeshri, and thank you, Raksha. And a big thanks to Dr. Anuradha and the entire IMA fraternity. It's great to be back in touch again. And it has always been a very, very fruitful and enriching collaboration for me as a person and for SVYM as an organization to work with such bodies as the IMA and the UNICEF. I'm sure the deliberations that we have had so far have definitely added a lot to what we already knew, gave us some new insights. So I hope in the next few minutes, I'll be able to share some components of what I feel are important and just take it forward as a collective. I hope you can see the screen.
Actually, it is not in a slide sharing. Yeah, now it is. Yes, sir.
Yeah.
No.
Yeah. So I'm very happy that the range of topics that are being covered today touch upon many of the hitherto unseen dimensions of COVID pandemic. All these years, we were more immersed into how the SARS-CoV-2 reshaped itself into a new virus, the damage that it causes in the lungs, in the kidneys and whatnot, and how oxygen is deprived, all those technically important aspects. But overall, these discourses, somehow we were missing out some of the very, very important components that I feel should have been in the main course, at least over the past few months. So often I use this analogy of a group of blind men trying to figure out what an elephant looks like. So if a doctor were to be asked what COVID is, he would have his own viewpoints, and a village sarpanch, maybe someplace in Bihar, if asked about COVID, would have his opinion as well. While the doctor's opinion is important in some ways, we have to understand that the sarpanch's viewpoints are also important because they have far-reaching implications on the community that he serves. So it's important that we see the unseen dimensions. We by tactile or whatever modalities, understand the big elephant that has multiple parts, compile it all together and understand that all of us were seeing one part, but there are so many other parts. So when the pandemic hit us, we were unprepared, and the pandemic continues to rage, and we still have the predictions that there would be a fourth wave and whatnot. But be that as it may, we have now come to what we can call the post-COVID stage. So we are already talking of the COVID as something that was there previously, but the truth is it's likely to stay on with us. And so it's going to stay with us for long. So some components of post-COVID and long COVID in the next few minutes. And what I feel is extremely important, particularly for the medical fraternity, is to be exposed to the reality that there is a non-COVID health issue and a non-health COVID issue. So these are two very important topics I feel all doctors have to be exposed on. And as we move ahead, I think there are certain important concepts and strategies that we as leaders of medical fraternity have to understand. So I'm trying to touch upon a few of them. I know we have already run out of time, and I'll try to make it as short as possible. The first topic that I'd like to cover is about the post-COVID-19 syndrome itself, the post-acute COVID-19 syndrome, as it's called. As I was saying, we were still grappling with what COVID-19 is, and we already have a new entity. We doctors are very, very fond of coming up with these terminologies, and we always spend hours and hours debating how it should be defined. This was no exception, but then there was a very, very methodical process that was adopted. The WHO set out to define what it means by COVID-19, post-COVID-19, by a very well accepted methodology called the Delphi Methodology, where experts from different fields, from different areas converge and enrich a particular topic with their insights. This was done in 12 domains. And as you can see from this map, the participants were from all over the world, sharing their observations and insights into what might constitute a post-COVID recovery scenario. So based on these months-long deliberations, the WHO came up with a definition which said that post-COVID-19 condition is that illness which occurs in people who have a history of either confirmed or probable SARS-CoV-2 infection. The onset of these symptoms should be within 3 months, and then the symptoms and the effects should last for at least 2 months. So these time durations are very important, though we know that most viral fevers are transient, have transient impacts on the health status. We have seen other viruses linger and cause long-term effects. And so as an effort to characterize the long-term effects of post-COVID, these components were included. And in this period of time, the big body of knowledge that was collected from world over identified certain key symptoms as characteristic of what can be termed COVID-19, post-COVID-19. And they include most common and most repeatedly mentioned symptom of fatigue, of shortness of breath, cognitive dysfunction. So these were the 3 most important and most repeatedly mentioned features. But that apart, there have also been multiple other components which we will come to. The current evidence predicts that approximately 20 to 20% of people who have recovered from COVID might get into what's called the post-COVID syndrome. There is also this terminology of long COVID. So like I was saying, doctors have a tendency to name things and rename things and debate about that. And so we have a new term, COVID, long COVID. There's a constellation of long-term symptoms, which some people carry for a long time, and they are often termed the long haulers. They carry it for a long time. So just as the WHO did its bit towards clarity emerging about post-COVID, we also had the CDC, the Center for Disease Control, coming up with its own attempts at defining what post-COVID syndrome could be. And interestingly, this definition categorizes the symptoms or features into three main brackets. One is what we just now heard, the long COVID component, and the other is the multi-organ effect of COVID-19, acute COVID-19 itself. And thirdly, and most important, which we oftentimes neglect, the long-term effects of the COVID-19 treatment and the hospitalization. So it's not just the disease, but the interventions that were done for the disease, which leave behind deep scars, very deep gashes that are caused by the COVID-19 disease, heal with extensive scarring, and they are ever-present reminders of the trauma that people went through. So as mentioned earlier, fatigue, dyspnea, brain fog, these are the most important components of long COVID. Multi-organ involvement, which is a feature of extensive COVID-19, leaving behind its marks on all organ systems, is the component of multi-organ effect of COVID-19, and long-term effects will come. So let's try to recall some clinical manifestations and how these manifestations can lead to long-term effects. If we look at the organ systems, we know that lungs were the favorite haunts of the COVID-19 virus itself. Destroyed lungs, characteristic of acute COVID-19. So we know the pathophysiology, extensive endothelial epithelial damage, ARDS, acute respiratory distress syndrome, clear decrease in the diffusing capacity, leading on to various immediate effects, dyspnea, cough, oxygen dependence, etc. Now, these pathophysiological changes that occurred during the acute phase of COVID-19 have been shown to be closely linked to long-standing dyspnea and long-standing exercise intolerance in as much as 40 to 50% of people by the end of third month. And there's also a report of more than 6% of people continuing to be oxygen dependent in some way at 2-month follow-up. So lung destruction is a key factor which leads to certain common clinical features of post-COVID and long COVID. Cardiovascular manifestations have also been extremely critical, though the direct virus-mediated cytotoxicity did not get as much importance as lung toxicity. So we have seen that the ACE2 receptor mediated changes, the tendency towards myocarditis and pericarditis, and the conduction system, electroconductive systems, they have caused a lot many acute phase deaths as well. But it's important as we deal with the post-COVID situation to recognize that these pathophysiological changes have a tendency to leave behind certain clinical symptoms. Dyspnea, we spoke of as a lung complication. It's also a cardiac dyspnea. Extensive fatigue and exercise intolerance, chronic myocarditis, decreased cardiac reserve, autonomic dysfunction, parasympathetic, sympathetic systems acting up on the rhythms, leading to significant arrhythmias, have been shown to persist in the post-COVID-19 recovery phase as well. Hematological manifestations have also been a very important finding in the pathophysiology of acute COVID. We saw that there were extensive thrombotic phenomena, embolic phenomena, leading to assumption that the hypercoagulable state is a characteristic feature of COVID-19, the consumptive coagulopathy, DIC, etc., which were so commonly seen, and these leading to certain persistent clinical features of increased risk of thrombotic complications. So actually, this is something that we have seen in the clinical practice in the past few months as well. Young people coming up with unexplained thrombotic phenomena, though the role of long-term to this particular complication as well. The neuropsychiatric manifestations, we spoke about this a bit earlier. So the pathophysiology of the neuropsychiatric manifestations include the microvascular thrombi, systemic inflammation syndrome itself, and the neurotoxicity of the virus itself, leading to neuropathology, which is seen in acute COVID. But these acute changes in the physiology of the nervous system, leading to certain very distressing symptoms of dysautonomia, post-traumatic stress disorder, post-COVID-19 brain fog. These are components that are repeatedly coming to fore and are being reported. But equally important, we also have a fairly long list of documented evidence of loss of cognitive function, cognitive impairment in COVID-19 patients, though they have recovered fully from a point of view of the direct manifestations of acute COVID-19. So these are things that we have to remember. At the same time, there are some reports of renal manifestations, though they are not very commonly reported. Endocrine manifestations have been reported in the form of increased challenges to glycemic control. In our own cohort, we had a situation where glycemic control post-COVID was a problem, continues to be a problem. DKA and thyroiditis have been reported weeks after recovery from acute COVID-19. And again, as an orthopedic surgeon, this would be something of importance, direct importance and relevance to me. Bone demineralization, especially in an already osteoporotic segment of elderly. So that's something that is being predicted and identified as well. This multi-system inflammatory syndrome in children, the MIS-C, as it was acronym, is something that most of our pediatricians are well aware of. Most of our clinicians have also heard so much about, and there was a fear that the third wave would actually hit our kids, hit our children in a big way. Lucky that it did not, but still, that is something that we have to keep in mind as we move ahead. So it's important that we get this multi-organ potential persistence of symptoms, so that in our clinical practice, as we move along, when we see certain relatable symptoms that patients come with, we have a bell ringing in the back of the mind that, oh, okay, this could be post-COVID. What have we actually seen in clinical practice? We do continue to see acute COVID, but then we have had so many tragic instances where our young friends, active individuals, some of them doctors, have suddenly died, collapsed while actually, having maybe a walk, or maybe doing some exercises. Young people, sudden deaths. So these are relatively unexplained, and the incidence seems to be of alarming increase. My cardiology friends have been reporting, have been documenting and sharing with me that there's an increase in the thrombotic events that they are seeing. And as an orthopedic surgeon, I get to see a lot of joint pains, heel pains, lateral epicondylitis or tennis elbows, as we call them, the enthesopathies, which indicate a high level of inflammatory process that's still going on. At the same time, we hear a lot of people coming back and saying that they're unable to get back to their regular level of activity, some form of fatigue, some lassitude, some inability to touch their original level of physical tolerance and physical performance. And we have seen exacerbation of pre-existing conditions like diabetes and irritable bowel disease and gastritis, etc. And a lot of post-traumatic stress disorders. The first, second, as well as the third waves of COVID-19 in India hit us personally as well. I know of very close relatives who went through. And I also know that many of them still wake up in the middle of the night with horrible memories of what they went through. So this post-traumatic stress disorder is a very important component that we need to keep in mind. Yes, there are all these anecdotal reports of complications that are described by the CDC and the WHO that we are seeing. But then I would like to put in a word of caution. We need to tread carefully and generate true evidence before we create more such clinical entities. Like I was saying, we always love these clinical entities. Give it a name, give it a definition, jump to conclusions. We need more studies from our own cohorts. I'm sure many of you would have had vast experience in handling direct COVID-19 cases. It would be great if you could follow it up and see what the status is 6 months down the line or a year down the line, and see if we really have that sort of a post-COVID tsunami that's likely to hit us. So what we need is a balanced approach. We shouldn't get complacent and be blind to the elephant in the room. We don't want our heads to be buried in the sand, and we don't want ourselves to say that, hey, nothing is wrong, we are all fine. We need to keep our eyes and ears open. But at the same time, we shouldn't get carried away and attribute a cause and effect relationship without evaluation. Even to this day, I get many patients with knee pain who come back and tell me that they've been having this knee pain ever since they had that chikungunya. Many of you would have handled the chikungunya epidemic as well, which hit us a decade or more ago. And they were all down with arthritis. And anything that happens to joints is now related to the chicken fever that they had. So it shouldn't be the same thing with COVID as well. So we shouldn't be carried away by what's called the Kakataliya Nyaya. A crow sits on a branch and the branch falls. So crow sitting on the branch caused the branch to fall. So that sort of cause-effect relationship is always a risk that we have. So we should be looking at these scenarios in a very, very critical and evaluatory manner, because otherwise we tend to have more than what we can chew. So this brings us to the next stage of my sharing, and considering that it's close to 4:30, I just would like to find out whether I can use maybe 5 or 6 more minutes to share some thoughts on the non-COVID and the non-health components of the pandemic. Is it all right, or?
Yes, sir. Yes, sir.
Hello?
Yes, sir. Yes, sir.
Yeah. Okay. Thank you. I'll try to rush through. Yeah. So when any catastrophe hits us, it's obvious that we will be ill-prepared or at best partly prepared. So the initial steps will always be drastic, and we swing from one end of the spectrum to the other end, one end being complete lockup and lockdown to complete indifference and irresponsibility. So this mental swings of the moods of the community is very visible. There have been many encouraging, reassuring efforts at the global, regional, national, and subnational level, which have made a tremendous impact on the care of the ill. COVID-19, how do you treat them? How do you generate the necessary manpower? How do we make ourselves better prepared? How do we strengthen the different tiers of care so that you catch it early and treat it early? A lot of political policy level measures, including the now famous lockdown and restrictions, to system issues, to policy directions, to strengthening the knowledge levels amongst the policymakers, etc. Excellent research and research capabilities that have been built, even in people who were hitherto not into research. Very encouraging trends there. And it's not just about COVID as a disease, as seen by the medical professionals. We saw a lot of mathematical modeling concepts emerging, looking at a lot of epidemiological models coming up to manage the whole scenario. And at the same time, we saw a lot of things happening at the community level. We talk of communication in a new way. Panic gets a new meaning. We saw how panic-stricken people were. when this COVID hit us. And viral now has a new terminology. It's not just about a virus as you and I doctors know, or a microbiologist or a virologist know. Anything that is circulating on any social media is viral. So how did this happen? So what is the role that media can play, the electronic media, the social media? How does that change community behavior, influence community behavior? So these are all extremely interesting and important lessons of processes that we need to take into account. We have also seen that there has been a new normal that has been defined in all dimensions of life. And that is something that we have to come to terms with, be it education, be it livelihoods. A lot of new things have been accepted as normal. Now, there are many, many studies which have tried to look at the impacts of the measures that were taken to counter the disease itself, including measures like lockdown. So what comes out as an interesting and important lesson is that the fact that people were asked to stay back at homes and things were all shut down definitely contributed to COVID-19 being contained, but then it spawned a new set of problems. So there was excessive mortality that was reported from almost all countries, Italy, England and Wales, morbidities that were reported at significantly high levels from the UK and from Switzerland and so many other areas. And there were so many non-COVID health dimensions that suddenly became visible. Children and adolescents did not get COVID all right, but then it's not that they were not affected. Their schools were shut down. They couldn't meet each other. They couldn't socialize. There were a lot of developmental issues. There were a lot of emotional challenges that came up. Substance abuse have been reported to be high. Socioeconomic impacts, the mortality that's associated with already existing diseases in the elderly, that shot up. So a lot of such changes that were going on have been very well documented for lessons for us to move ahead. And equally importantly, we need to look at it from an equity lens. So one important message that I feel we should all learn and imbibe is that yes, there was a pandemic, all right, but then it should also be a syndemic, which should lead us to synergistic interaction with all the related stakeholder groups. So going beyond health, we need to look at how equity is addressed, how livelihoods are addressed, because we just now heard from Savita how the COVID-19 pandemic actually impacted economy. So economic deprivation is not in isolation to health deprivation. So they are closely linked. And if you want public health, economy has to be fairly strong. Yeah. And we had waves after waves, all countries across the globe, all strata, but then it hit some people more than it hit the others. So who were they? That is something that we need to look at. So if we want health, we need to look at all the dimensions that impact health. And this is something that the SDG framework tells us. So as a member of the Freshwater Action Network that was mentioned when I was introduced, we try to look at how the real people at the grassroots were faring during the COVID-19 process. The people whom we addressed, that we tried to hear, were the ones that were marginalized and are likely to be forgotten, or not even, they don't even come on the radar. People like sanitation workers, persons with disabilities, slum dwellers, homeless, the LGBTQ community, female sex workers. So what did they say? The sanitation workers, they had such heart-rending stories to share. They would say, we clean the whole world, but then how about our own cleanliness? How about a toilet for us? We don't have them. Everything we touch and handle is harmful, including your masks we touch, we dispose, but then no protection is given to us. Persons with disabilities, shanty dwellers, there was a group whom we spoke to in Hyderabad, outside Hyderabad city. They said with tears in their eyes, we built this city, we built so many of these areas in the city, but today we are not cared for. In this scenario of lockdown, we are not even there in the whole policy framework. You shut down the toilets and the taps that's open for public, and what do? Where do we pass stools? Where do we pass urine? These are some things that most of the times we don't even think of, because the dimensions of impact are multiple. We can't be fixated on just the health part. We need to look at all the entire spectrum of impact that COVID has had, and address them adequately. So that is when the framework of SDG also makes some real sense, and gives us some solid footing to actually build back better. So as we move on, we need to look at addressing health determinants as a whole, look at some components, very importantly, on health security, universal health coverage, and resilience. And this slogan of LNOB is something that's a favorite of mine: leave no one behind, to make sure that there is equity and inclusion, and we make sure that nobody is left behind as we move forward in achieving our goal of health and well-being for all. So that can be done not just by the right corner extreme component of healthcare system, but a whole lot of contributing factors, including economic stability, environment, education, food security, social security, safety, and community context. So these can be achieved by multiple means, and the health sector needs to work with all these components, all these factors, all these stakeholders to move on. I think I'll skip to the last slide in interest of time, and recall that the prayer that IMA has adopted, the original of the prayer that IMA has adopted, Natvaham Kamaye Rajyam, Na Swargam Na Apunarbhavam, Kamaye Dukkhataptanam Praninam Artinashanam. I do not seek kingdom, I do not seek heaven, not even rebirth. I only seek alleviation, the pain of the suffering creatures. So we as medical professionals are in this holy profession because of this particular value that we have tried to adopt. And I hope this crisis binds us all together, enriches us as we move ahead in our quest to make sure that Sarve Janaha Sukhino Bhavantu. Thank you.
Thank you, sir, for the knowledgeable session. Coming up, the last session on immunization challenges during pandemic by Dr. Ranganath, sir. I request Dr. Anasuya ma'am, IMA Bengaluru branch trust member and consultant cardiologist working as BBMP medical officer, to introduce our guest speaker.
Hello, thank you for that one small wonderful introduction. Good afternoon, everybody. Can you all hear me? Hello?
Yeah, we can hear you.
Yeah, so it's my pleasure, and I'm very happy to be part of IMA, and I would like to thank IMA for giving me this wonderful opportunity. It's an honor to introduce Dr. Ranganath sir. He is a professor and HOD in the Department of Community Medicine, Bangalore Medical College and Research Institute. And is one of the special officer for Karnataka Nursing and Paramedical Science Education Authority. And he is also an editor-in-chief of RGHS National Journal of Public Health. And is the secretary of Karnataka Association Community Health, and is also a convener in Medical Education Unit. And he is having a tremendous contribution in this COVID situation, being a nodal officer for COVID-19 vaccination in Victoria Hospital, and is also a team member of the State Surveillance Unit of COVID-19. Being the professor as well as secretary of the Karnataka Association of Community Health, he has done a wonderful in his department, and I'm very happy to introduce Dr. Rangnath sir. He was my professor also. And let's hear from him the immunization challenges during this pandemic. I welcome you, sir, and over to Dr. Rangnath sir.
Thank you, madam. First of all, I thank the organizer for giving me an opportunity to share this my little knowledge with my young friends. Thank you, madam. The topic what given to me as immunization challenges during the COVID pandemic. Of course, my earlier speaker and even Sitaram sir has very well explained regarding this, the scenario and the sufferings and what is the required during the pandemic time and all. So I would like to share my knowledge regarding our experiences, what we have done in the Victoria Hospital. It's one of the COVID hospital. I'm just speaking not only COVID, just to share with a little COVID, then I'll go to the other vaccines. Maybe another few minutes, my topic will be on immunization services, the challenges and the recommendations according to my little knowledge, right? So we'll be covering this, the routine immunizations, of course, covering this, my earlier speaker, Dr. Nagaraj, and everybody has covered. So in this routine immunizations, the 12 vaccines, of course, in the routine immunizations, then a mission in the 4.0, pulse polio, and COVID vaccines. All those things we'll be discussing this. In the routine immunizations, as we know, this about a 12 VPDs, the vaccine preventable diseases, were under this national immunization schedule. We are covering this. Of course, in that, we all know because of this, the COVID, last 2 years, most of this manpower is directed towards this COVID-related activities. So this routine immunization is definitely as hampered. A child who is, for example, if a child is about 1.5 years, 1.5 months, or 2.5 months, it was due for the second dose, third dose. Suddenly, this COVID come in between this. So most of the childs are the gap. The first dose, second dose was delayed. So because of lockdown and all, they were not able to come. So in such case, whether the government has not given any clear guidelines or people also get confused. Suppose the child is due for this 1.5, 2.5, and 9 months and 1.5 years. If the gap is increased, what should be this? Something like this. There are so many questions, but things are continuing this. So vaccinating the newborn babies as well as up to 5 years, that is under 5 vaccination. And regarding this, similarly, the more than 30 million post pregnant mothers immunization across India, something like this. Similarly, we know this, the mission Indradhanush, that is mainly to immunize the unimmunized children. So it is supposed to start from this February itself, because with COVID and other issues, again is postponed, maybe March, April. So this is also covering those things. If you look at this, this one of this picture, recently our, this is what, one of the activity in Bangalore Medical College. So with my team, so our medics, paramedicals, my postgraduates, this is our strength. So they all shared this, their work for this, the pulse polio, like this across Karnataka, across India, in all districts, all health department, everybody, all doctors, nurses, and grassroots workers, ASHA workers, everybody has worked for this pulse polio, of course. So this pulse polio, what I would like to say, the 2 or 3 things when we are doing in the field regarding pulse polio, earlier it is there since 1994-95. Used to do every in the media like oh bun zindagi ke liye. There is some advertisement in the TV media and all. But since last 10 days, 15 days, because it's nothing but Russia-Ukraine war or nothing but this the COVID earlier. So in between this, so this publicity or EEC activities towards the pulse polio has disappeared. Of course, people has know that there is a pulse polio vaccine is going on. Mothers are aware of this. My child should be vaccinated, but still that should have been emphasized. But this is another one what we feel this in the field scenario. So this is also another activity like every child of under 5 has to be vaccinated, and all the health workers across Karnataka, including my center also, the people are vaccinating this the polio drops. If you come to this COVID vaccination, I would like to share my few thoughts regarding this COVID vaccination. Of course, our Victoria Hospital, I'm not just boasting. So it's one of the hospital, we have treated more than 17,000 patients. So 17,000 in that, almost nearly 7,000 patients are on ICU or high this one. And almost similarly, proportionately, when there are 17,000, it is 3,000 deaths were reported in the last 1.5 years. Since March 2020, something, if I am right. Fine. So most of their So with related to this vaccination, of course, in the first wave and second wave, there is no vaccination. Most of them, they were because of this comorbidity and other severity of the disease, people are died. So in the middle of the second wave, this January 2021 onwards, vaccination come. So in that also we analyze this death audit. It has shown that majority of the people who are not vaccinated or unvaccinated or partially vaccinated children, persons who are dying. So this was the death was more so in the unimmunized persons compared to the vaccinated person. And also we could see 86,000 plus were vaccinated in the one of our hospital, and including this as the government order, like case of frontline workers, health workers, general publics, and all those things. But in our hospital, my experience is when you are vaccinating with the affluent society, VIPs, and the highly educated persons, it is extremely difficult. So because we have faced that if you take the example as COVID vaccine as an immunization. So in that we have seen in the two extremes, wastage as well as shortage. I said both in the beginning, their vaccine was supplying, but people were hesitant to take the vaccine. Maybe they are not waiting on this government system. Slowly, somehow the vaccination is picked up in between. So people are aware of there is a good vaccine to save the life. So people have started coming at a mad rush again. So this crowd control and this vaccination, and meanwhile, while vaccinating, this documentation process, of course, it was a part of this activity, but it made a very big challenge for the healthcare workers. It made us very tight. So instead of doing this work, this other work like documentation, whether the person is having the Aadhaar card or ID card, or whether it is a category of person, whether it is a frontline or any other common man or an adolescent or geriatric, identifying and putting in this system, because otherwise for first dose, second dose, we have to. So it is a big challenge what we faced in the COVID wave. Meanwhile, along with that, in the middle, in between, we got this vaccination for the antenatal and postnatal mothers. That was also a big challenge because convincing the mother that it is also safe and to save for the both for the two lives. That is a challenge. Later, hemophilia patients. So because they are also more vulnerable. So we know this, the hemophilia is a bleeding disorder. Even if the person is simple, a small injury, he will get a big bump here. So in such case, if any before giving the any COVID vaccine, we have to take extra precaution. Whether the person having the particular factor deficiency, we have to identify that and you have to give the first factor deficiency. Then you have to give that COVID vaccine. After giving the COVID vaccine, to avoid the bleeding, we used to give the ice packs or cold packs, something like this. For another half an hour, he has to sit for sitting observations. So all these procedures will made it was not an easy task. Thank you. So whether it is a routine immunizations or whether it is a routine immunization or Indradhanush or pulse polio vaccinations. So this COVID has got a very good lesson for this health department, not only health department, I think for all the departments. So this is the small, just my experience regarding this. Then what are the challenges? What we face was, as I said, it's the manpower. During this COVID time, most of this manpower, including our own hospital, I think it's a universal phenomena in the entire Karnataka or in all states. The manpower is a big shortage. Wherever whoever available, that is pulling for either for the COVID care center or CCC or treatment center or something like this. So most of these routine activities are neglected. So definitely, so the vaccination and to be achieved. So the gap was widened. So the manpower is a big challenge for this, whether it's a doctor and even to treat the person in the hospital. That was a big challenge everywhere that is faced. Similarly, vaccine supply. I said shortage as well as wastage. So now I'll just share this few lines. If you take example as the COVID vaccine, now what I said, beginning people were not coming, vaccine hesitancy, because of the vaccine hesitancy that 3-4 hours the vaccine has to be used. So that used to be, initially there was a lot of wastage, vaccine wastage, like the COVID or Covaxin, the life-saving vaccine, we wasted like anything. But sorry to say, but the fact is fact. So we are wasted in the beginning, people, there is a hesitancy, so the vaccine wasted. Now, as and when the second wave and third wave, as it's back, coming to the end, so again, people are reluctant or careless, so they are not coming in a good number. So whatever the vaccine, now more so COVAX. More so if I see the COVAX vaccine, now the available is about the 20 dose vial. So Indians, we have very less, what is called as a patients. So they will not wait in the vaccine, not able to ready to wait for a few minutes in the vaccination center. They will come and they ask for the vaccine. If I ask you to wait for 2-3 minutes because we have to, because a 20 vial dose. So once if I open within few minutes, that a few hours that has to be emptied. So it is not happening. Now also I'm just wasting this. So maybe this is with the manufacturer or the supplier. The COVAX is supplying the 20 dose, that is a lot of vaccine is wasted. It's happening this. It's unavoidable, but even if I say come tomorrow, they may not turn up. So vaccine supplier that has to be, and sometimes it happened that I do agree, maybe among the 12 routine vaccinations, maybe about a few vaccines like rota vaccine as well as PCV vaccine, pneumococcal vaccine. That is in some centers, we heard that in our own centers, there is a few lacuna in supplying this. Even if the one day, one child or something like this, that gives a word of mouth, a bad impression. So that supply should also be sufficient. That is also a challenge we face this. Then the migration, of course, as Sitaram said, during the COVID time, people are especially more so in the what I've seen is migration in the more so in the rural urban areas, urban slums. We say when the particular area, we know this is the population in a particular slum, and respective proportionate children to be vaccinated. So because of this migration, it makes the person to migrate from this for this livelihood, either from rural to rural, urban to rural. So most of the people, they left their places. So this migration made that to planning for this vaccination is a big challenge. Whether we don't know how many have gone out or how many have gone in. So it is a big challenge for us. And the hampered immunizations. Yes, of course, during this COVID time, most of this manpower, maybe about doctors, teachers, and all those suppliers, they are all patients with a COVID disease, just like any other common man. So when the health force is down with this disease, so then who are there to give the routine vaccination or to conduct the pulse polio, to conduct the mission Indradhanush? Again, the same old persons. So this is also hampered our immunizations. So because of all these poor immunizations, we all definitely agree that poor immunization, that is the child is more susceptible for infection. Again, because of the infection, there is a malnutrition. Because of malnutrition, it leads to the poverty. Because of poverty, out-of-pocket expenditure. Sorry, is recently just now is explained that is a vicious circle, and we know this. So with a little knowledge, what we suggested was, of course, a designated COVID team. Because it's a COVID time, government has made this in most of these local bodies, they have hired this either COVID doctors or COVID healthcare personnel, something like this. If it is so, then the person designated for the RCH activity or for these immunizations, definitely they will carry out, and they has to do this, they will do this. If there is a mixing or putting this all the burden on one cadre, again, it will hamper it may not. So maybe a designated team, it would be ideal. Then increase the productivity and supply of this vaccine. That is what happened in the COVID or maybe about the rota or other vaccine. So if the supply is better, definitely the vaccination will be the good. Similarly, reaching the migration populations is a big challenge. That we know this. Maybe in the rural urban areas, this can be happened with a special outreach camps. Of course, many people have gone out from the urban slums to these rural areas, and after some time they get come back. So they will settle in a particular areas. So because in a city like Bangalore and other major cities, people work for this, has to work every day, they has to earn. Otherwise, they will be their family should be live with an empty stomach. So they have to go for work. So that means they will not come to the hospital for this vaccination alone, because they may know the less importance of this immunization. So we doctors or health personnel has to go to the field. So the special outreach camp has to be conducted whenever there is a settlements are there. We have to conduct the outreach camps, that is conducting everywhere in Bangalore and other areas. They are doing this. This is the one way they are doing this. Similarly, in urban areas, UHND village, village and urban areas, nutrition days has to be conducted. Similarly, outreach immunizations. So whenever there is a chance to get this, either in the rural area, something like the Sri Shakti Mahila Mandal, where there is a meeting of the mothers. So the ASHA workers or the grassroots workers will share their knowledge regarding this is the time has come now. Your child has due for this one, whatever this. So the vaccine due for the child, that will be discussed and we can bring down. So this is also recommended and it's happening this in almost all areas. Similarly, the IEC activity, just now I said, recently I finished the pulse polio program. Hardly media or TV and the electronic media are highlighting the pulse polio program and coverage. Nothing but the Ukraine or Russia war. So it's purely that we have to intensify the IEC activities and the beneficiary of immunization. Earlier we used to do with the celebrities, film stars, cricketers and all, but now this has disappeared in the COVID time. So this has to be improved, so that then only, because repeated enforcement make the person to remember and things, so that because a healthy child and a wealthy nation. And a follow-up. Of course, when the child come for this vaccination, second dose, subsequent booster doses, where are the child? So that has to be carried out. of course, the strong political commitments and to combat the malnutrition camps. Just now, as you seen this cascade circle, so the infection susceptibility, malnutrition, out-of-pocket expenditure, along with the Women and Child Department and the Education Department and the medical colleges, across these medical colleges, all the 60 medical colleges, starting from Chamarajanagar to the Bidar, private, government, everybody is doing their malnutrition detection camp in that respective areas. So this indirectly helps when the child come for these things, the doctor or the community medicine or the pediatrician, whoever are there, they will check for this child. And if there is any lacuna in the vaccination, that also be covered. So this is also one of the method that they are doing this. So malnutrition detection camp is also going on. So these are some of the activities during this last 2 years activity conducted. These are all opportunities to create awareness among the mothers to bring the child for vaccination and to improve the status. Whether it is a VHND or Mahila mass meeting, all those things. In those times, so this our ASHA workers, other things, they will interact with the community and they will create an awareness and to ultimately to immunize the whoever the eligible vulnerable population, the child or a mother has to be vaccinated. A small team from this Bangalore Medical College, so overall they are all staff nurses like CH, we call it as community health nurses. Just now sir has showed that health and wellness centers. So the health and wellness center, the staff nurses, they are all part of this. So they were also used for the other thing. There is a very good opportunity for the student learning and also we use for those things. Thank you for giving an opportunity. I'm sorry for I've taken long time. Sorry for the inconvenience. Thank you.
Thank you for the wonderful session, sir. The session is now open for discussions. Dear delegates, any questions, you can unmute yourself and ask our guest speakers.
Madam,
Deepak, sir?
yeah, can proceed to vote of thanks considering the time constraints. They can write to us. I have given a details. So they can write to us if any queries. For e-certification, so except the registered members can write to these mail IDs.
Every special moment ends, and this occasion is no exception. But we are sure the session ended with installation of knowledge. Last, but not the least, we request Dr. Satyavati Ma'am, Secretary, IMA Bengaluru Branch, working as BBMP Medical Officer, to conclude the program with the vote of thanks.
Thank you, Dr. Raksha. My heartfelt thanks to Sri Vivekananda Youth Movement, Indian Medical Association, UNICEF, and Karnataka Association for Community Health. I sincerely thank our President, Dr. Anuradha Parmesh, who has organized such webinars and will keep on organizing webinars and CMEs to increase our knowledge. I thank the speakers, Dr. Nagraj, NT, and Dr. Mishbahani, surveillance medical officers from WHO, who have been training us, and I being very fortunate to listen to them again and again. It's a treat to hear to you, sir and madam. I thank Dr. Rangnath T.S., Karnataka KACH, Secretary of KACH, Karnataka, Professor and Head Department of Community Medicine, BMCRI, for giving us extensive knowledge on immunization. I also thank Dr. Sitaram sir, Managing Trustee of Disha Foundation, for increasing our knowledge. I thank Ms. Savita S., Chartered Accountant, and I thank all the participants who have participated in this webinar. Thank you.
Thank you all.